Yeah, Dr. Prashant, you may start now.
Hello, good afternoon, doctors. Welcome to this webinar on experience sharing program on Carbetocin. Today we have got Dr. Hernaz Kaur with us. Welcome, madam. This program is
Thank you so
sponsored by
much.
Hetero Healthcare. Healthcare has got 20 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have a distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID era, Hetero Healthcare introduced oseltamivir, favipiravir, and remdesivir, the pioneers in antiretrovirals, for which we received an award of Pharma Excellence August 20 for COVID drugs. Today's program, Experience Sharing on Carbetocin. Once again, I welcome Dr. Harnas. Dr. Hernaz Kaur is graduated from Delhi University and Sion Hospital, Mumbai. Madam has undertaken training course in OBGY, ultrasound and fetal manufacturing, IVF workshop with Reliance IVF Center. Madam has presented paper in AICOG Hyderabad 2011, member of Navi Mumbai Obstetric and Gynecological Society, life member of FOXY. Madam is well versed with IUI procedures and ovarian stimulation protocols. Dr. Kaur has undertaken USG for fetal well-being and follicular studies. Currently, Madam is attached to as consultant to Raj Gobind Hospital, Raj Gobind Nursing Home, Kargar, Motherhood Hospital, Kargar, Ashirwad Hospital, Nerul, and Cloud9 Hospital, Vashi. Dr. I'll run the slides, madam.
Yes, thank you so much, Dr. Prashant.
Yes.
We
Yeah, yeah,
would be starting our talk now. Kindly
yeah.
share the slide.
You can see, madam?
So, shall I start?
Yeah, yeah, please. Start, madam.
Uh, can you please start with the first slide? Or shall I just start from here?
Oh, yes, start from here.
I am seeing right now overview of postpartum
Correct, correct,
hemorrhage.
correct. You can start from here, madam. You can see this? You can see the slides, now, madam?
Yeah.
Please start.
So today the topic of our yes, I think you've started with the
Yes, yes.
postpartum hemorrhage. Yeah. So today we will be talking about the topic for our webinar is about the drug, the very prevalent and if good effective drug that is carbetocin, which we are presently using it in PPH. Before I talk about carbetocin, I would like to brief you about postpartum hemorrhage and what exactly it is. Yeah. So postpartum hemorrhage is loss of blood at least 500. Previous slide, please. I would ask you to change the slide. Yeah. So postpartum hemorrhage is loss of blood 500 ml following vaginal delivery or around 1 liter 1000 ml after cesarean section due to various certain causes, which we'll be discussing in our further slides. PPH is common and can occur even in women who are not at risk, but it is one of the leading cause of maternal mortality and morbidity, especially in a developing country like India, and it is primary cause of the maternal deaths globally. Next slide, please. So, as you saw it in the picture, that PPH occurs when uterus cannot contract on its own and it lands up in an atomy. That is, the uterus is not able to contract and the vessels are not able to constrict, due to which the bleeding from the vagina is just continuous, or during cesarean section, the bleeding from the uterus is continuous, leading to postpartum hemorrhage. So, as I mentioned, causes postpartum hemorrhage causes maternal mortality. It is one of the leading cause of the maternal deaths, accounting for 35%. And maternal mortality rate, if we talk about, is around 240 per 1 lakh live birth, compared to 16 in developed countries. So in India, you can imagine how many women every day they are dying because of postpartum hemorrhage. And the global incidence is around 2 to 4%, and PPH in India, which is important for us to know, is 38% of the maternal deaths. So that means, uh, which is very high compared to the global deaths occurring due to postpartum hemorrhage. The maternal mortality in India is quite high. So we need to consider this as a very important cause and treating it at our utmost priority to combat this and lessen this rate. Next slide, please. So, as I was telling you about the various causes of postpartum hemorrhage, some of them being the tone, that is uterine contraction, inability of the uterus to contract, thrombin. It could be due to any coagulopathies, blood disorder, which a mother might be having, due to which she's bleeding profusely, or any trauma to the genital tract, or retained placenta. Next slide, please. So, clinical findings in PPH. There will be abdominal tenderness, circulatory prolapse, that is severe hypotension, and increased abdominal girth, loss of uterine contractions, maternal tachycardia, and severe vaginal bleeding. So there are various degrees of um shock to signify the grade of PPH. For example, if there is less than mild in the compensatory phase of PPH, we are expecting it to be the blood loss in between 500 to 1000. Blood pressure may or may not uh, change, and signs and symptoms will be palpitation, dizziness, tachycardia. And if there's mild PPH, the blood loss expected is around 1000 to 1500, due to which there will be slight fall in the BP and there will be weakness, sweating, tachycardia. We will label it as moderate PPH if the blood loss is between 1.5 to 2 liters. There will be a marked fall in the BP, restlessness, pallor, and oliguria. And in case of severe PPH, when we say the blood loss is more than 2 liters, there is profound fall in the BP, and there will be the collapse of the circulatory system, air hunger, and anuria. Next slide, please. So diagnosing, how will we diagnose? So these symptoms will help us to diagnose, and there should be rapid evaluation, examination at the time of hemorrhage, so that we can grade the degree of PPH, and also we should assess other causes like genital tract lacerations, hematoma, uterine rupture. We should look for any manual uh, examination for retained placental tissue. There should be availability of bedside ultrasound to check if the uterus is contracted, or any of the product of conception are still lying, due to which the uterus is going into atony. And we should also check for uterine inversion. And we should send the necessary lab investigations, that is complete blood count, including hemoglobin, hematocrit, and platelets, and coagulation profile. Next slide, please. So, as discussed earlier as well, if there's poor uterine tone, that is uterine atony is observed, we have the clinical findings will be the uterus on per abdominal examination will be relaxed and flabby. The fundal height will be increased, and in blood investigation, we should be sending the blood investigation once that this has been diagnosed, and patient should be started with IV fluids, and other investigations should be traced as soon as possible. And the management part, we should start with uterotonic agents, that is oxytocin and oxytocin like derivatives, for example, carbetocin, that I'll be talking in further slides, and various other methods like uterine ballooning tamponade can be uh, done. And if they are expecting any tear in the genital tract, uterine rupture, we should try to repair it immediately, either by local area exploration or laparotomy can be performed. And other methods like to curtail the bleeding, if this is not helping, pelvic arterial embolization can be tried. And if the cause of PPH is retained placental tissue, examination under anesthesia so that the patient is comfortable, and a vaginal examination to check for any retained placental tissue can be performed. And if coagulopathy is the cause and none above are noted, then we should be checking for the blood investigations and immediately act according to the investigations suggesting the changes in the blood profile. So the aim is to identify the cause in women who are bleeding in parallel with resuscitation. Next slide, please. So, as I mentioned that we will be giving uterotonics. So now I'll be talking about a very new molecule, which is heat stable formulation, carbetocin. So carbetocin is available in room temperature stable formulation, and it is in a convenient vial preparation. So if we compare uh, the difference between carbetocin to other uterotonics. So carbetocin is stable at room temperature, whereas oxytocin and other ergot derivatives, they should be kept in refrigerator, because otherwise the potency of the drug will be hampered. So next is the heat stable formulation of oxytocin is currently unavailable, whereas at room temperature, the potency of carbetocin is still maintained till 24 months and has a good shelf life also. So, um, next slide, please. Oxytocin and other ergot derivatives, they are available in ampule form, but carbetocin is available in a very convenient vial form, which is easy for any staff nurse to use in time of emergency. Discussing about the time of administration of these uterotonics, that is oxytocin, carbetocin, and others. We can give them at the time of crowning of the baby's head, or at the time of delivery of anterior shoulder, at the end of the second stage of labor, or following delivery of placenta. Prophylactic use is prevention of PPH and active management of the third stage of labor. And therapeutic use is management of PPH. Next slide, please. So, talking about carbetocin, it is a synthetic long-acting analog of oxytocin. Therapeutic indication is postpartum hemorrhage due to uterine atony. Posology and administration is one vial which contains 100 microgram of carbetocin in 1 ml solution for injection. So this formulation of carbetocin prolongs the half-life and reduces the enzymatic degradation. Next slide, please. So carbetocin, if we talk about its difference between our conventional oxytocin, so oxytocin, it is a synthetic molecule which mimics the naturally occurring hormone, oxytocin hormone, secreted from our posterior pituitary, posterior pituitary. Whereas heat stable carbetocin, it is a long-acting synthetic analog of oxytocin with agonist, and oxytocin If we give oxytocin intravenous, it has a peak action immediately, but it lasts only for 30 minutes. Whereas if we give carbetocin intravenous, the action starts in 2 minutes and lasts for almost 60 minutes. IM oxytocin, it has a slower onset, that is 3 to 7 minutes, and provides an effect to 60 minutes. Whereas intramuscular carbetocin, the action starts in 11 minutes but lasts for longer, up to 2 hours. Oxytocin has a half-life of 1 to 6 minutes, whereas carbetocin has a half-life of 40 minutes, which makes it a very stable molecule, safe for storage, and safe even administration without thinking of degradation in its potency or in its formulation. So the clinical indication, carbetocin is mainly indicated for prevention of PPH, whereas oxytocin is indicated in all other um, stages of labor. Next slide, please. So if we talk about the trials being conducted for carbetocin in postpartum hemorrhage, so many RCTs are conducted. Approximately 30,000 women across 10 countries were included, including India, were taken. So the outcomes were that the proportion of women with blood loss of at least 500 ml or the use of additional uterotonics was significantly reduced, and the proportion of women with 1000 ml blood loss were hardly found with appropriate usage of carbetocin. Next slide, please. So this again, this slide depicts the efficacy and the stability of the molecule comparing carbetocin with oxytocin. The conclusion being that carbetocin is no inferior to oxytocin for the prevention of blood loss. In fact, after the use of carbetocin, the need for other uterotonics is significantly reduced. Next slide, please. So the Cochrane review, which was conducted, it stated that carbetocin for preventing uh, this postpartum hemorrhage, the data was noted involving multiple women, and multiple studies were conducted, and which resulted that there was significant reduction in the need for therapeutic uterotonics compared to oxytocin when carbetocin was used, and the blood loss also was significantly less even in vaginal deliveries and cesarean section deliveries after in the group of women in which the carbetocin was used. Next slide, please. That too with very few adverse drug reaction noted. Next slide. So guidelines for postpartum hemorrhage prophylaxis. There have been multiple studies conducted with multiple group of societies which they have given their recommendation, that is WHO guideline, SOGC guideline, RANSOC New Zealand guideline, FIGO guideline, Germany guideline. Everyone do suggest and uh, prescribe, mention about carbetocin 100 mg IV bolus dose for its efficacy in management of PPH across many countries all over the world. Next slide, please. So I'll be also putting some case scenarios for you so that you understand where we can use carbetocin and where it has significantly helped in obstetric emergency. Presenting our first case, which is G6 P3L3A2 with 39 weeks gestation with previous 3 normal deliveries, presented with spontaneous onset of labor. On examination, pulse and BP vitals were found normal. Uterus was termed cephalic presentation. Fetal heart rates were good with good uterine contractions. So the patient progressed fast and shifted to labor room. On per vaginum examination, os was 7 to 8 centimeter dilated, 80% effaced, and station was +1. Patient delivered. At the time of placenta expulsion, injection carbetocin was given in view of grand multiparity. So, anticipating PPH to happen and giving carbetocin on time helped in uterus being contracted immediately and no PPH noted. Next slide, please. Primary gravida with IUI conception 39 weeks twin gestation presented with early labor pain, fetus A being breech presentation, estimated fetal weight 2.8 kg, and fetus B transverse lie, estimated fetal weight 2.4 kg with PIH. On examination, general condition stable, pulse 90 beats per minute, BP 130/90 with urine albumin 1 plus. Per abdomen, uterus was overdistended. Multiple fetal parts were palpated. Fetus A, heart rate was 154, and fetus B, heart rate was around 148 beats per minute. Uterus were irritable. Vagina 1 centimeter dilated. Bleach fell. Membranes plus, show plus. So the plan for elective LAC is taken in view of fetus A breech presentation. Intra-op, both baby delivered, PPH noted in view of over distended uterus and also PIH. Uterus was found to be flabby. Immediately injection carbetocin 100 mg IV bolus was given in view of PIH and over distended uterus. So almost post expelling of placenta, uterus has started contracting nicely and no further uterotonic was needed. Post-op, the patient was found to be stable and minimal vaginal bleeding was noted and uterus was well contracted. Next slide, please. So the third case is G2P1L1 with previous full-term normal delivery, female child, presently she was 37 weeks and 37 weeks of gestation. She presented in labor room. On examination, vitals were stable, pulse 92 per minute, BP 127/70. And per abdomen, the examination, uterus was term, cephalic, fixed. Fetal heart rate was 138 per minute. Uterine contractions were pretty good, 3 to 4 per 10 minutes, lasting for 30 to 40 seconds. And on per vaginum, os was fully dilated, fully effaced. Station was also quite low, down, +1/+2. Patient delivered by cephalic presentation. And it was noted that placenta did not expel even after 20 to 30 minutes post-delivery. So the manual removal of placenta was attempted, which was also uh, added with injection carbetocin was given 100 mg IV bolus, which helped in uterine contraction. Uterus started contracting immediately, helping in the manual removal of the placenta and expelling of the placenta without much of the bleeding. Next slide, please. So now I would talk in detail about
Yes.
carbetocin.
So, madam, you shared your experience. In all these cases, you have preferred IV formulation, IV route, or IM route, madam?
IV route. IM route, I hardly remember, but because I'm so confident in IV route itself,
IV
it
route.
was
Huh.
never a stance, yeah,
And this
that I
IV,
needed to.
and these are all
Once I
emergencies.
think post-op, yes.
Yes, these are emergencies. We will definitely go for faster onset of action, which would happen with IV route.
Yeah, yes. And plus, yes, one uh, patient after delivery in my ward, when the patient was shifted to ward, she had gone into uterine atony and PPH was noted.
Oh,
In that case, in that patient, I had given an IM injection. That too, it had given me a good result.
correct. The duration of IV injection slightly longer, I suppose, as compared to IV
Yeah, but with along with good uterine massage, I could
massage.
achieve it.
Yes. And although PPH can happen in any patient, is there a specific patient profile where you can anticipate a PPH?
Pardon me, I did not get your question.
PPH can happen in any patient we know, but is there any patient profile where you can anticipate a PPH or where patient PPH is
Yes,
going to be
why not?
likely to
The three
happen?
cases, yeah, the three cases which I mentioned, apart from my daily routine, these were the three cases which I picked up because I knew that I will be expecting PPH in those cases. For
Uh,
example, multiple gestation, overdistended uterus, PIH patient, or grand multiparity. All those are cases which in which maybe I'm anticipating uh, this PPH
PPH.
plus oxytocin being having a shorter half life. I mean, I would need a longer monitoring of that patient.
Correct. Are diabetics more prone for PPH, madam?
Diabetes, yes, especially I mean a known case of diabetes patient
Uh,
and known case of um, a hypertension patient.
Hypertension. They are more likely for
Yeah, yes,
yes.
yes.
Because maybe
Complications of
correct,
gestational
correct,
hypertension. Yes.
correct. And maybe in diabetes again the atony of uterus would happen because of little
Yes,
large size
again
baby
because of
section.
the
Yes, yes.
big baby,
Uterine
yeah,
routine.
big
Yes,
baby
yes,
over distended. Yes.
yes, yes. Actually speaking, when would you prefer carbetocin over oxytocin? More of a your own experience.
Yeah. So that's what I'm saying, in which I'm anticipating
Ah,
PPH,
PPH. Correct,
in which I'm anticipating PPH not only on table but also in ward also, maybe after
correct,
2 hours also. Yes.
correct,
Then
correct. Yeah.
because carbetocin having a longer shelf life, I prefer carbetocin in those cases.
Mm, okay. But is there any experience of retained placenta? Although you shared one case, but any experience where retained placenta where the drug is used and giving results?
See, now this case which I mentioned, I wasn't
Uh,
anticipating. Retained placenta, you cannot predict. So
mm,
definitely, oxytocin was given first, and I could not remove the placenta, though the uterus has started
yes,
contracting.
yes,
But
contract.
again, since there was a retained placenta, uterus had become flabby after some
Flabbed.
time.
Correct,
Yes.
correct.
So when second time I observed that uterus has become flabby, I immediately administered carbetocin. So with the effect of carbetocin, when the uterus started contracting, it helped in expelling the placenta easily.
Placenta. Correct. And what about RH negative mothers, madam? Because this could be an emergency in RH negative, PPH in RH negative mothers.
But I don't think there has been any study noted that it is any contraindication or anything like that.
Correct, correct,
We
correct.
can use.
We can use. Can a doctor use a carbetocin for prevention of PPH if oxytocin is used for labor induction? We commonly use oxytocin for labor induction. Can you use carbetocin afterwards for prevention?
Yes, yes, we can.
The drug would act on the same receptors, but there would not be any problem like
Yes,
children will
yes,
use.
but I feel that uh, uh, oxytocin being a very short half-life, once you
Ha,
disconnect the oxytocin, so
the
from the
effect
time of induction to the expansion of the baby, 20-30 minutes have passed.
हो ही जाता है correct. And in the receptors would recover in the meantime.
Yes, yes.
Yes,
Again,
yes,
the receptors will be free for the carbetocin to act on the drug.
correct. In which case would you prefer IV or IM?
In my this OT, OT itself means emergency. In my OT, I will always prefer IV.
But anesthetics do they have any role in choosing these uterotonics or it's the gynecologist who decides?
In my setup, the gynecologist decides.
Gynecologist, but otherwise anesthetists will just guide.
Yes,
They follow the gynecologist. So gynecologist is a key person who decides.
yes.
And there'll be some cases where patients do not respond adequately with carbetocin. What additional uterotonics would you use?
We can give ergot derivatives.
Argot derivatives you can
Alkaloids
give.
can be, yes, yes, yes,
And even prostaglandins you can use.
yes.
Like, specifically asking what are the advantages of carbetocin over oxytocin? I'm specifically asking in terms of ADH side effects.
Yeah. So, carbetocin mm, does not have much of any. Number one, I would say the body stats, vitals will remain
Oh,
constant.
okay.
Then fluid retention, hyponatremia as compared to oxytocin is not seen.
Is not seen.
Carboprost, yes, carboprost cannot be given in patient asthmatics.
Asthmatics.
Methyl ergometric cannot be given in RH negative or cardiac.
Hypertensive, yeah. Yeah, even cardiac
So,
patient.
yes, yes.
And specifics,
Misoprostol cannot be given in patients who are allergic to the drug.
correct. Any specific side effects with misoprostol or carboprost? Like fever, like shivering.
Yes, definitely. It is noted with. So that's why I mentioned that carbetocin does not causes any changes in the body stats. So
Okay.
patient does not have any, yes, symptomatic changes नहीं होगा.
No.
Carboprost definitely immediately causes purging, diarrhea
Okay.
like feeling,
Oh, that will be a mess.
nausea.
There's a mess
Yes.
there. Yes. Yes.
On table itself, they have
Yeah,
purging.
it's a mess. Yeah. So, in case
Yes, and
carbetocin, yes,
misoprostol, if we give, sometimes the anesthetist administers sublingual misoprostol and on table in OT itself, they start developing shivering.
shivering, no? So, get prostaglandin related. So, I mean, suppose carbetocin doesn't work. The next drug will be methyl ergometrin or misoprostol.
If what is not working,
Carbetocin, suppose you have to giving, you need another drug. Which one will you use amongst this?
yeah, if carbetocin, then my preference would be depending on the again on the
Yeah,
patient. Oh,
correct, correct.
um, I would like to first go for methyl ergometry.
Methyl ergometrin, correct. I mean, assuming that patient doesn't have cardiac, hypertension, etc., etc.
Yeah,
Yeah, yeah.
everything has its own
Yeah, yeah, yeah,
contraindications.
correct, correct, correct. Plus and minus तो होता ही है.
Yeah.
It should carbetocin kept as a reserve drug or it should be used as a first line. Especially, because oxytocin is our textbook brand. So there are many people who feel that oxytocin is काफी है. So they keep carbetocin as a reserve drug. So should we take it as a first line drug?
See, like if you ask my honest opinion, then it is that uh, carbetocin should be kept as first line drug in
Correct.
which we are anticipating PPH.
PPH, okay. हाँ.
ठीक है? And yes, and especially for a like gynac setup where it is easily accessible and everything. But no, I'm sorry. Gynac setup में you can keep oxytocin because the staff is trained. कितना
Gynex,
ampules डालना है, कितना dilatation.
the gynex
So,
setup means I did not get what is gynex setup.
uh, so for example, if it is a maternity home,
Okay, maternity home.
see the staff will be trained about oxytocin.
Yes, correct,
कितना
correct,
ampules कितना है.
correct, correct.
Uh, but in a tertiary center
Right,
where the sister of ICU can also come, she'll not
absolutely.
know how much oxytocin. So carbetocin in such setups should be the
First
first line
drug.
drug because
This is very
yeah,
interesting.
because it is
Yes,
heat stable. Nobody has to rush.
correct,
It can be kept along with the boiled trolley at the time of cesarean section itself.
correct, correct.
So no titration is required. 5 unit, 10 units like that.
Nine, 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 huh. And it's a single
Immediately
shot.
one while. Yeah,
Yes, a
yeah.
single shot. Do you use it as it is or you dilute it and use carbetocin?
Pardon me.
Carbetocin you use as it is or you dilute it and use as
I
infusion?
I have tried either method. If
Either
I
method.
feel there's a new person in the OT,
Yeah.
and so I'll ask them 1 ml ka 2 ml kar do and give it over 1 minute because it should
Correct.
not happen कि blood देख के they get scared and they are pushing it fast.
Correct, correct, correct. That can happen.
Yeah.
How do you compare side effect profile of all these drugs?
I feel carbetocin is quite safe with hardly any contraindication and
Yes.
compared to oxytocin or the other uterotonics. It is very safe, convenient to use, and without any Post-administration monitoring.
This is your final take-home message for people, especially for those who are a little hesitant to use Carbetocin. Your final message, your
So,
experience.
yeah. So the final take-home message is, if you are anticipating PPH in a delivery, let it be a vaginal delivery or a cesarean section delivery, you should use carbetocin as first line of drug without even giving it a second thought कि अगर ऑक्सीटोसिन काम नहीं किया तो हम कार्बोटोसिन दे देंगे, because till then you have already lost 1 liter of blood if it has not worked, because at
Right.
that time if you administer carbetocin after oxytocin, there will be a limitation. You may not get the response immediately. But if you are using carbetocin in an anticipated case, you will get the response immediately without any need of other uterotonic.
Right, madam. I mean, thank you very much, madam, for your experience. And it was really wonderful, especially this insights into a gynec setup and a tertiary care setup. This is very interesting because those people would be. I mean, thank
Yeah,
you very much. Thanks for your time, and thanks the marketing team, thanks the sales team for this coordination. Thank you IT team for a super coordination. And wishing you a very good evening. And you can sign off, madam. Thank you.
yeah. Thank you so much.
Thank
Thank
you. You can log off, madam.
थैंक यू सो मच मैम।
Thanks, Bivas. हो गया ना दोनों क्वेश्चन?
बहुत बढ़िया एकदम।